Hi, this is Michael White. I'm going to talk about a variety of different topics relative to the emergency department. So, just kind of things that I learned over my time in the emergency department. First and foremost is I always like to shoot for excellence, the gold medal. I believe that represents arrive to provider greeting the patient less than 5 minutes, getting the low acuity length of stay, certainly less than 50 minutes. Honestly, I think it should be less than 40 minutes at goal. Overall discharge length of stay, again, excellent is less than 90 minutes. I think it's very achievable to do less than 70, and I've done that in a very busy emergency department with a team of one ER doc, myself, and everybody else being family practice. And finally, greet to admit dispo, and again, this should be less than 80 minutes. But again, if we can get less than 100 minutes, we will definitely be best in our market. So I've introduced this idea of the front end mechanics numerous times. The idea is patient comes in, sees the greeter, gets put in the computer, and then there's multiple entry points to triage depending on the overall ER volume. Here it shows 3. The provider sees, evaluates the patient, has a shared discussion with the patient regarding testing and planned disposition, and then orders tests and waits for the results to come back. This is a provider-led department, and I think that's the way every department should be run. The question sometimes I encounter is, does it work? And I'm not going to belabor this, but you can see overall discharge length of stay, 4 and 5 discharge length of stay. We got down to 48 minutes and 76 minutes for overall discharge length of stay, and that's for the entire year. And we saw a precipitous drop in our LWATs as well as AMAs, and the patient satisfaction was 95th percentile. So in general, there's 2 types of patients. At least this is how I think about it. There's the ones that go home and the ones that don't go home. Now, there's the medical diagnosis of what stays and does not stay, but in reality, you're not going to send somebody home that's not safe to go home, whatever the reason. Patients also be transferred, but that would go under the does not go home patients. A lot of providers will talk about ESI levels. I'm not a fan of ESI levels. ESI levels represent an estimation based on nursing assessment of utilization in their department. I think if the provider sees the patient and makes a decision and creates a direction of care for the patient, then this should be what leads the patient along the pathway. Nursing does have to put their ESI in for compliance, but that is not something we should follow. So there are the 3 types of patient. You think discharge, you think admission, or you're uncertain about what the disposition is. I throw those in the admission category, and you think transfer. If you're thinking discharge, then you should be thinking about specific tests that are required to get the patient out. You're ruling out an emergency. If you think admission or you're uncertain, this is where you're going to do more of a one-time bolus testing and treatment. You really want to get that done up front and put in so that the nurses know exactly what to do. Nickel and diming is death to a department. Last one is you think transfer. Honestly, if I'm thinking transfer, I start the process as early as possible. The bottom line is I don't believe I have the resources to provide appropriate care to the patient, so the best care will be at another location, and the best for the patient is to get them to that other location. So just in brief, for a low acuity, and low acuity is our money, arrive to be seen by the provider, less than 5 minutes, evaluation by the provider, again, this is for a prescription, and then or a rash, something very simple, and then discharge, and you're looking at about 25 minutes. For a basic x-ray, worried about a sprained ankle, similar as before, and that's being generous, saying the testing takes 20 minutes, but even with that, it should be 45 minutes. So you put those 2 together, the average of those 2 should run about 40 minutes for the department for your low acuity length of stay. So how does this play out with quality of care? Obviously, we're here to provide the best care for the patient. And these are the metrics that I had available at that facility. And you can see door to TPA dropped more than half. And this was TPA given by the provider without teleneurology. So they would make the call based on their evaluation. Door to antibiotics, and you can see the significant increase. And that's simply recognition of the provider of what potentially could be sepsis. There is a discussion of sepsis later in this presentation. And then last but not least is severe sepsis and septic shock mortality. This should run easily 10 to 15%, and you can see we got it down to 1%. So I'm going to talk somewhat, and I told you this is kind of a potpourri of different opportunities for low acuity processing. So I broke it into the upper part of the body, the mid part of the body, and the lower part of the body. The upper part of the body, pharyngitis, bronchitis, otitis media. I don't think any testing really needs to be done on this. With pharyngitis, you're evaluating for possible strep, but the reality is what we're treating is the possibility of retropharyngeal abscess, which is about 1 in 900. The risk of strep pharyngitis is incredibly low. The original studies that looked at the pathogenicity of strep pharyngitis were done, I believe it was in 60 or 62, in military recruits, and I believe it was in Wyoming, 2 different studies. They both had negative outcomes, and those studies have repeatedly been attempted to repeat over many years, and nobody can repeat them. And the thought is that it was a particularly virulent strain of strep that they were exposing the military recruits to at that time. Bronchitis is not pneumonia. If you think it's a pneumonia, you can still look at the vital signs and treat accordingly. Of course, you're going to risk stratify these patients. If you're 90 and you're worried about pneumonia is very different than if you're 35 and worried about pneumonia or bronchitis. And then otitis media, the vast majority of otitis media is actually viral. It's probably somewhat north of 95%. Therefore, you can give antibiotics. However, it's debatable how effective those are because obviously they don't treat a virus. Abdominal pain, I don't spend too much thought process on this. I risk stratify into high risk and low risk. I mean, that's what ER doctors are doing. So abdominal pain, I'm going to obtain, if I'm worried about it, I'm going to obtain a CT scan. If I'm not worried about it, I can treat symptomatically and have the patient come back. Similar with kidney stones, CT scan, unless one's been done in the last year. It's one of my pet peeves. The reason we get CT scans in kidney stones is primarily to rule out other diagnoses. Namely, what else will give you flank pain and hematuria? Is a AAA that has cut off the blood flow to the kidney and it's becoming ischemic, and so you want to make sure that's not there. What I'm looking for on the CT scan is really to make sure there's not a AAA there or some other alternative diagnosis. Kidney stones are fine. I can pick those out relatively straightforward on a CT scan and then have the conversation with the patient. I like to do a lot of discharge and have the patient follow up on their results on their own, or I can call them with the results. It's a similar thing with pharyngitis, going back to that. If somebody wants a COVID test, I have no problem swabbing them and calling them when the results come back and letting them know what the results are. Last but not least is, again, vomiting and diarrhea. That in itself is symptomatic treatment, plus minus some fluids. Usually Zofran does a wealth of good. However, you have to make decisions based on risk stratifying the patient. Vomiting and diarrhea in a 90-year-old is very different from vomiting and diarrhea in a 12-year-old. Dysuria, I am a fan of treating even without testing. Clearly, you can get testing if you would like, but how does it change your management? If you get a urine back and there's no white cells and they say it burns every time that they pee, the predictive value is very good that they have a UTI and it will come out on a culture. On the other hand, the predictive value of a urinalysis that shows 6 to 9 white cells but no symptoms is relatively low. Similar with an STD, I am a fan of going ahead and treating. Obviously, PID needs to be evaluated differently. You can also have patients self-swab, or you can do GC chlamydia off of a urine specimen. Caution is to make sure that you keep in the back of your mind about syphilis, since that's significantly on the rise across the country. So a few more opportunities and pet peeves. I'm a dad who has 4 kids, and I see a lot of kids being treated by what the providers assume the parents want. And I can tell you, as a parent, the easiest thing is simply to ask. Not all parents want swabs on all their kids. Sometimes they just want to know that something bad is not going on. Some parents do like swabs, and again, you can swab and have them follow up. but having the discussion with the parent is very useful. Very often, the parents just don't want their kids to suffer, and so it's discussions about hydration, tolerant Motrin, and other symptomatic treatment. I'm not a big fan, actually, I'm an anti-fan of giving cough medicine. Sometimes I'll give a steroid, especially a single dose of Decadron, which I'll discuss later, but generally I'm not giving cough medicines to patients unless the family's demanding, and then I do a short course. Which brings me to another point I should have addressed on the previous slide. If you're going to treat pharyngitis or UTI or whatever, you have to decide the duration. There's not really good literature on the duration of treatment. There is literature suggesting that oral medicine's as good, if not better, than IV medicine, and that would be similar for IM medicine. There's also literature that suggests in a healthy person a single dose of antibiotics is generally good enough to get rid of an illness. Therefore, I usually treat for no more than 3 days. I certainly don't do a 7 or 10-day course. Orthopedics, one of my pet peeves is seeing people order an x-ray without talking to the patient and asking them if they need crutches or a splint, regardless if there's a fracture. Obviously, if there's a fracture, you can do something different. However, if the patient needs crutches and a splint to go home for a bad sprain, then you might as well order it up front. So I want to talk some about mitigating your risk in the emergency department. Like I said, ER providers do risk stratification, and so a low-risk practice to me is a practice where you're going to listen to the voice in the back of your head. You know, I call it my guardian angel looking over my shoulder, making sure I don't make mistakes. It's not perfect, and sometimes I overorder, but I never feel bad about doing that because I've caught a number of awful diagnoses simply by listening to the voice in the back of my head, and very often those diagnoses were not obvious, even on retrospect. Vomiting and diaphoresis, you got to be respectful of both of those. It doesn't mean you always have to do a workup. However, if somebody comes in sweaty, I usually address and ask them if they know they're sweaty, and sometimes they'll say they sweat all the time, and that's okay. Similar with vomiting. Pain out of proportion, this is a hard one because we're very biased in assuming that some patients come in and are a little histrionic or dramatic. However, I'm very cautious about pain out of proportion. It's helped me catch a number of ovarian torsions in my career. Abnormal vital signs are vital, and therefore abnormal ones need to be addressed. It doesn't mean you have to correct it, but if it's elevated and I discuss with the patient their heart rate's elevated and they say it's always elevated, then I document that. However, I don't just blow off vital signs. I'll have those discussions with patients, and I certainly document that. Bounce backs are incredibly high risk. It doesn't mean the previous workup was inappropriate or wrong. It just means that, number one, the disease process may not have presented at that time, or number two, that something was missed. And so I take a fresh eyes perspective on this. I get pushback from the nurses, but the literature is robust about the high-risk nature of bounce backs. Turnovers, my wife and I work together, and she's a better clinician than I am. However, she turns me over a patient when she's working days and I'm working nights. I go in and independently evaluate that patient. And finally, AMAs. AMAs are one of the highest risk categories. If your risk of getting sued is approximately 1 in 30,000 patients, an AMA risk of getting sued is about 1 in 300. Talk a little bit more about that later, but basically AMAs are viewed by the patient as termination of the relationship, and they're resistant to come back to the emergency department. So I like to have a shared decision making. Let's say they don't want a test, or they don't want to stay for longer observation or be admission. You know, I break my AMAs into two groups: those that have high probability of going home and dying, such as somebody having a STEMI and then wanting to go home and feed their dogs, and I absolutely have them sign the AMA, and I have multiple people talk to them. Then there's the patients who, let's say they're borderline for admission, but they want to go home. I have a thorough conversation with them, and then I use what I call my AMA disclaimer I put in, which outlines that discussion, which includes the risks of going home, and it also asks them to please come back. I am also a fan of giving them prescriptions. I do believe this represents best care to the patient, even if they're declining to do what I want to do. I don't have an adversarial relationship with my patients. I'm there to work with them and partner with them to their betterment. And one of the nicest things I can think of is when a patient declines, goes home, and then comes back later. It makes me truly happy to see that happen. So, like I talked about earlier, we risk stratify. You see somebody and you think discharge. What you're doing is risk stratifying in your head. What's the risk of that patient going home and having a negative outcome? Same thing for admission and for transfer. You could keep a patient in your hospital, borderline, but if you don't have the appropriate resources and things go south, then the patient would be in the wrong spot. So we really need to think of all of our patients in terms of risk stratification, which goes to the next thing. The marginalized patients in the world are ones that tend to be overlooked and can have horrific outcomes. And they're ones that we generally have a bias against. So number one is my bias when I see a patient. I'm very sensitive to myself when I know that I'm judging somebody. And when I'm doing that, I tend to overorder to compensate for my own bias. This includes folks that are homeless, haven't bathed, have a strong odor, people that use drugs, alcohol. Psychiatric patients very often get overlooked, but a lot of those patients I just discussed have a lot of underlying chronic medical conditions that need to be evaluated. And if you blow them off and it's something that's decompensated, they will have a very poor outcome. So let's talk about mitigating lawsuits and taking advantage of opportunities. So there's two broad classes in my experience of why people get sued. One is they mess up. They did something stupid. There's not much you can do about that. Certainly being a patient advocate and nice to people is going to reduce your risk. However, none of us are God. We all make mistakes. Number two is that the provider is difficult with the patient. Maybe you're rude to them. Maybe you're tired. I don't know what it is, but you bring it in and the patient and you have a negative interaction. I can't tell you the number of times that I've had a negative interaction with a patient. I walk out to the desk, I cool off, I document some, and I go in and I apologize to the patient and let them know that I'm sorry that we got off on a wrong foot and what could I do to work with them. And it's amazing how respectful they are and positive they are about this interaction. It shows what I think is key in medicine, which is humility as well as a service mentality. AMAs, I talked about this earlier, about the partial AMA. And again, I do not have them sign the form when I do a partial AMA because that form is viewed as a termination of care, and the patients often feel like they are not allowed to come back to the emergency department when they fill one of those out. And then the real AMA. I'm always encouraging my patients to come back regardless of why they go home and tell them I am more than happy to see them at any point in time. You know, one of the golden rules is to treat others as you would want yourself to be treated, and that's just treating others with kindness and respect. And if it helps, you can think of your family members and how you would handle them in these situations. So here's some diagnoses that are what I consider to be high-risk diagnoses. You know, viral, whatever it is, viral sore throat, viral stomach bug, viral bronchitis, there's no need for the viral there. In fact, even for bronchitis, I don't diagnose that, and I'll discuss that more later, but I'll put cough and congestion. I'm not a fan of diagnosing viral pharyngitis. Just pharyngitis is perfectly fine. Gastroenteritis is another high-risk diagnosis. The reason being is there can be underlying issues that come up related to the gastroenteritis. So it could start off as a viral infection and end up being appendicitis. There's no benefit to diagnosing gastroenteritis. You can diagnose vomiting and diarrhea with abdominal cramps is perfectly fine. Constipation, I don't view constipation as a source of abdominal pain. So I will find a diagnosis and try to avoid the diagnosis of constipation. It's amazing how many charts I will see that will have a diagnosis of non-cardiac chest pain or atypical chest pain. And I'm not sure even what that means because having done this for a long time, it's really hard to know what cardiac chest pain is, let alone what's non-cardiac. So I just avoid those diagnoses. Needless to say, diagnoses such as anxiety, drug seeking, and chronic pain, you got to be very careful about those diagnoses. They can definitely lead you into a lawsuit if you get it wrong. I want to talk briefly about quinolones. There's certain drugs that'll get you in trouble. Quinolones are one of those. You know, back in I think it was the early 2000s, droperidol was a drug we used a lot as a fantastic drug. One study showed a concern and the FDA placed a black box and everybody stopped using it. Quinolones have 4 separate black box warnings, and yet I still see people use it. It has relatively poor coverage because of resistance, can cause a tendinopathy, QT prolongation, hypoglycemia, and peripheral neuropathy. They're also, depending on which ones you're using, can associate with C. diff. And they tend to be the most dangerous in folks that have chronic medical problems, are older, or are on steroids, or you're giving steroids. So I really see close to no use of quinolones in my practice. When it comes to things like diverticulitis, I'm a fan of Augmentin. My wife likes to say a provider deserves the test that they order. There's non-specific tests out there that get you in trouble. A BNP is one of those. Chest x-ray is more sensitive. Clinical exam is sensitive. A BNP is not as sensitive. What's worse is when I see people saying the BNP is super high as justification for something. Similar argument for D-dimer. Troponin test. This one's a little bit tricky. You have a low-risk chest pain. You don't think it's cardiac. EKG looks okay, but you order a troponin, and it's non-specific. What do you do with that patient? You own that test now. Similar for a urine drug screen. It's a non-specific test. It wasn't designed for what we use it for. If it's negative, it doesn't tell you much. If it's positive, it very often is a false positive. Similar for a SED rate and CRP, unless you have specific diagnoses that have defined ranges for those. Those are high-risk tests because they can open you up to litigation by showing you inflammation, but really don't help you that much clinically. And a lactic acid, it's a double-edged sword. Honestly, I tend to order more lactic acids, and then I do it knowing that some of those are going to be elevated, and then I have conversations with patients about keeping them and repeating the test or explaining why the test would be high. However, the downside of not doing a lactate is missing somebody with a significant underlying pathology. I picked up a number of patients by obtaining a lactate and then responding to a surprise lactate number. Diagnosis, we talked about pharyngitis, bronchitis, sinusitis. Personally, what I'm getting at here is if you use those diagnoses, then, for pharyngitis, you can give antibiotics if you order a strep test. Doesn't mean the results are back, just that you ordered it. Bronchitis and sinusitis, you cannot, per the government, give antibiotics to those. Those are viral illnesses. Now, there are workarounds. There's things such as bronchopneumonia, if you hear some cronkles in the lungs, if you hear wheezing, so you could put bronchospasm. Sinusitis is a little bit trickier unless they have pharyngitis and you strep swab them. But otherwise, those diagnoses, and I get into a little bit later, should not be given antibiotics. You can do steroids, though. Now, having said that, if I have somebody, and again, I'm getting a little ahead of myself with the MIPS measures, but if I have somebody and I diagnose them with bronchitis and they want an inhaler and steroids, or if I'm not going to give them antibiotics, they want an inhaler and steroids, then I definitely diagnose bronchitis because you get a positive check on that. Similar with sinusitis, let's say they don't want antibiotics. They want to do some steroids and then a nasal spray, and then I definitely diagnose that because I'm not giving the antibiotics. There are some diagnoses when you do this, you have to do that. For example, if you diagnose non-STEMI, you need to put a heart score in. You diagnose STEMI, you have to put a heart score in. You diagnose ACS, which is the same thing, you don't have to put a heart score in. It's a workaround. So if you see somebody, and let's say it's a STEMI, not initially on presentation, but later develops into a STEMI, and you diagnose ACS, you will not fall into the guidelines. Stroke, similar kind of thing. If you diagnose stroke or do a stroke alert, then you got to put in an NIH stroke scale score. And if you're thinking sepsis, just use the order set. There's no risk of not using the order set, except that you will fall out, and then you get on the CMS website as low quality of care based on your noncompliance with recommended evaluation. So let's talk a little bit about money. There are some non-billable diagnoses. Diagnoses such as MVA, fall, weakness, animal bite, and that includes any kind of animal, are not billable. So for animal bite, I can put puncture wounds, I can put contusion, put abrasions, lacerations, extremity pain. For fall, again, if they hurt something, then I can put that in there, similar for MVA. However, if let's say they come in and it's a baby that was in an MVA with in a car seat that was asleep and has no exam findings whatsoever, you can diagnose normal exam, but it does not help you to diagnose MVA because it's not billable. So compensation, we all like to get our compensation increased. To justify increased compensation, you have to be able to see patients and be productive, which goes back to the patient per hour, which you're only going to see a significant patient per hour if you are having efficient throughput. And again, ACEP recommends that to be around or over 2 patients per hour. And in our program, it's going to be hard to get to that point. However, that should be allow you to be able to be efficient in your documentation as well as your throughput. So for documentation, you want it complete. You don't want to be missing review of systems, physical exam. Those are all down codes. You want a comprehensive evaluation. You want to document any procedures you do. Any procedures is anything that you do to the patient. So you put in a nasal trumpet, you put in packing for a nosebleed, you put in a Foley catheter, you put in a central line, you clean a wound, anything like that, and you document it. It can be billed. I have pre-made statements for all that stuff, and I will put them in as dot phrases so folks can use them if they'd like. Critical care, I'm going to talk a little bit more about this in the next slide, but we tend to far underdiagnose this or underutilize this. So what is critical care? A brief, very brief, is 2 non-oral interventions and a life or limb-threatening condition. So I like to think of somebody that comes in, severe asthma attack or anaphylaxis. So severe asthma attack and they're young, I give them breathing treatment, steroids, maybe some fluids, maybe a little magnesium. They turn around, they want to go home. Again, this probably, if it was severe to start, I would put in as a partial AMA because generally I like to keep those and have those observed. But I wouldn't make it a formal AMA unless they're still in respiratory distress and declining to stay. Anaphylaxis is a great one. So they get bit by a bee, they come in swollen up, you give some Benadryl or non-sedating antihistamine, steroids, and epinephrine. They turn around and want to go home. You have done, as long as you didn't do the antihistamines orally and steroids orally, then you have your 2 non-oral interventions, and it was life-threatening. So it's interesting because a lot of folks do not use critical care with sepsis, but I'm going to tell you that if you look, and I forgot the exact numbers on each of them, I believe the mortality of a STEMI is 7%, stroke is 8%, trauma is 9%, and just regular old sepsis, I'm not talking severe sepsis or septic shock, is 10%. It's actually greater than that, and I believe that's based on a 60-day or 6-month mortality. I can't remember the exact study. But I was surprised how high the risk of bacterial sepsis is. And then when you look at sepsis as a whole, you have sepsis versus severe sepsis and septic shock. Mortality of sepsis, let's put it at 10%. Severe sepsis goes upwards of 25%, and septic shock is all the way greater than 50%. So they are incredibly high and much higher risk than things that we conventionally look at for critical care. Other things that are critical care, such as AFib RVR, especially if there's end organ involvement, is another good critical care diagnosis. Certainly anything with BiPAP. So MIPS. MIPS is the merit-based incentive program. It's by CMS, and they change what's required frequently. This is a recent list. So number 65 was avoidance of antibiotics with a URI. Such as pharyngitis, sinusitis. The next one is bronchitis. The third one, 331, is sinusitis. 254 is getting an ultrasound to define where a pregnancy is. And 187 is for stroke. And 415 is for blunt injuries. 416 is for pediatric. And basically they want to avoid doing CTs on these folks unless absolutely needed. So if you're going to do it, you need to put in the criteria explaining why you're doing a CT and a low-risk head injury. So sepsis is huge. There's 2 measures that we talk about, the MIPS measure and the SEP1 measure. and there's the difference between the two. But basically, there's a lot of overlap. What you want to do is recognize sepsis, and again, there's three types of sepsis. There is the sepsis that is from a non-bacterial source. That'd be like the flu. They're going to meet criteria for sepsis, but that's not somebody you're going to admit. The only ones we worry about in sepsis are the ones we're going to admit. Then there's the ones that are obviously septic shock. They come from the nursing home, 102 fever, and open wound or whatever. That's obvious. The third group is what I call my cryptic septic patients. These ones are the hard ones to pick out. These are the ones that'll give you a surprise lactic acid. But this class is somebody like an elderly woman who's weak and dizzy who ends up with a UTI. And she was septic. It was just hard to tell that because you don't know if it's a stroke, it's chest, it's cardiac, it's whatever, and it ends up being sepsis. So when I'm thinking admission, so my first step is if I think admission, then I think, is there any infection? And really what I think about is infection or inflammation anywhere in the body. And if there is, then I start out with the sepsis order set. If I'm worried about infection, then I go ahead and I start the antibiotics on the patient. Please know for sepsis, really what they're looking for is anything that has an itis to it. So that represents inflammation in the body. And again, I agree pancreatitis is not standardly an infectious process. However, if you have the itis in there, it will very often fall in. Pancreatitis, pyelonephritis, gastritis, pharyngitis, bronchitis. If you put chest pain plus bronchitis, they will fall into sepsis if they, in severe sepsis if they got abnormalities on their vitals and elevated lactic. And again, with the abnormalities on the vitals, it is not just the triage vitals, it's any time during their stay. So let's say that you have somebody with chest pain, you're worried about bronchitis, and you give them a nitro and their pressure bottoms out. They could theoretically fall into septic shock for that if you diagnose the bronchitis. So going back to the provider deserves the test that they order. It also goes with the diagnosis that you ordered. If they have bronchitis and chest pain, but you don't diagnose the bronchitis and you just do chest pain, it won't fall into sepsis. As soon as you put that inflammatory response, infectious response is going to fall in. Let's talk about narcotics. Studies show that hydrocodone is better than oxycodone. Less side effects and probably better pain profile. Tramadol is useless. Toradol, maximize the receptors, meaning you filled them at either 10 or 15 milligrams. It doesn't matter if it's oral, IV, IM. It drives me crazy to see people giving 30 and 60 of Toradol when 10 or 15 is perfectly fine. And again, I don't use tramadol as much as possible. It's proven itself to be relatively useless. The other problem with oxycodone is it tends to prompt more of a drug-seeking tendency in patients that can start them down towards narcotic seeking. Steroids is another one of my pet peeves. A lot of people I see are giving methylprednisolone, and so they'll see 125 milligrams of methylprednisolone. I know a lot of people know this, but that's equivalent to 156 milligrams of prednisone. I don't know how many times people are giving 156 milligrams of prednisone. I certainly know that I am not. Dexamethasone, the equivalent dose to 125 milligrams of methylprednisolone is 25 milligrams of dexamethasone, which is a huge dose. I'm going to tell you what most people are going for with the steroid is the anti-inflammatory. And when you look at those three, which one's obviously has the most anti-inflammatory potency? That's going to be dexamethasone. We don't want to suppress the adrenocorticoid process, and the one that doesn't do that is dexamethasone, and then the half-life of dexamethasone is 36 to 72 hours. I love dexamethasone with my patients. I talked earlier about only doing 3 days of antibiotics. If I have somebody that comes in, and let's say that they have a bad cough, and I give them a single dose of dexamethasone, and then I write them for antibiotics because I think that they have pneumonia, and I write them for 3 days. Honestly, if they're not better in 3 days, I want to see them again, and at that point, the dexamethasone will have worn off, and the antibiotics would have had plenty of time to act. So abdominal pain, I started early with this in terms of what I look for. And again, I risk stratify. Now, let's say that I get a CT scan, it's negative, it doesn't show anything acute, but I'm worried about appendicitis or diverticulitis. Then I'm putting that patient on antibiotics. And again, I can just do 3 days and have them come back for a recheck. You got to understand, even in appendicitis with a specialist reading CTs for appendix, it's a 95% test. Most of our tests have a margin, and I can't think of many, if any, that are 100%. A lot of it comes down to our clinical gestalt at the end, which is that voice in the back of your head. But if you're suspicious for infection, such as appendicitis or diverticulitis, I err on the side of treating. There's a lot of good outpatient literature that supports outpatient treatment of appendicitis and diverticulitis. Anyways, that was a